chronic kidney disease is very common. As we get older, our kidney function decreases, so kidney function decreases with normal aging. But the commonest causes of kidney disease worldwide are diabetes and high blood pressure. And that is the largest cause of kidney disease. There are a number of other kidney diseases that we see. One type of kidney disease are diseases that affect the filters of the kidney. They're called glomerular diseases, of which a condition called IgA nephropathy is the commonest glomerular disease to cause kidney failure. Then there are a number of systemic diseases that can affect multiple organs in the body, and which can include the kidneys, and diseases such as systemic lupus, erythematosus, vasculitis, and myeloma can all affect the kidneys. Then there are a number of genetic diseases that can affect the kidneys, and inherited diseases include polycystic kidney disease, reflux nephropathy, and Alport syndrome. And then in elderly people, we often see narrowing of the arteries to the kidneys, so we see a lack of blood flow to the kidneys. And there are a number of other causes such as kidney stones, but those are the major causes. Most patients with kidney disease are unaware that they have any problems with their kidneys, because kidney disease is generally asymptomatic until kidney function drops below about 20% of normal. So that often they're picked up with kidney disease because they found to have an abnormality on a urine test or a blood test, or have problems picked up on a kidney scan, which is done coincidentally. But when people develop advanced kidney failure, they may develop the symptoms of fatigue, loss of appetite, weight loss, fluid retention, itching, cramps, or metallic taste in the mouth. First of all, I take a history and I examine the patient. I take the blood pressure, and then I do some very basic blood tests, and nephrologists like myself also organize some more specific tests to exclude systemic diseases. We quantitate the protein in the urine, and we organize an ultrasound with a very highly skilled specialized renal radiologist. So those are the first screen of tests that we do, and then depending on the results of those, we may need to do some second line investigations. And that may include further imaging of the kidneys, either with CT scans or even a renal angiogram, or if it's more appropriate, maybe more appropriate to do a kidney biopsy. But a kidney biopsy is a relatively invasive procedure, so we reserve that for patients who really need to have that done. So for all patients who have kidney disease, there are some generic advice that we give about lifestyle. So we advise patients to keep fit, to lose weight, to avoid salt in their diet. If they've got high blood pressure or diabetes, obviously to try and optimize those conditions. In terms of people with kidney disease, blood pressure control is very, very important, and we believe that the class of drugs called ACE inhibitors or angiotensin receptor blockers are for most kidney patients the best at preserving kidney function. Now in the early 2020s, there's a new class of drugs which is coming along called the SGLT2 inhibitors, which also look like they're going to have a very important role in slowing down the progression of kidney disease. Obviously, for some kidney diseases, there's some specific treatments. So some diseases which are caused by the immune system being overactive, you give some immunosuppression, which might involve steroids or other types of immunosuppressive drugs. If you find that a kidney's got obstruction, you ask the urologist to relieve the obstruction. And then for certain other conditions, such as polycystic kidney disease, there are some specific drugs that you can use. So the key here is to make an accurate diagnosis, to be able to tailor the appropriate treatment to the patient. In the United Kingdom, we have guidelines which try and help us to assess which patients need to be followed in the hospital and which can be followed in primary care. The follow-up really depends on what treatment you're giving the patient and how severe the kidney disease is. If someone only has very mild kidney disease, they can probably be followed by their primary care physician stroke GP perhaps once a year. On the other hand, if someone has got a disease that needs very intensive monitoring, they need to be followed much more closely. So kidney failure can now be managed even if you have severe kidney failure. So there are options which include dialysis or kidney transplant. The optimal treatment for young patients would be a preemptive live donor transplant before the patient needs to have dialysis. But that obviously depends on whether there's an appropriate live donor available. If there's no live donor, then in the UK, patients will go on the waiting list for a deceased donor transplant. If the patient needs dialysis, then there are a number of options. Patients can come to a hospital and have dialysis at the hospital, or dialysis 3 times a week, or they can have a home dialysis therapy, which could be either home dialysis, hemodialysis, or peritoneal dialysis.